Okay, well, it's a pleasure to welcome Maxi Strobl, former IMOR, and he just moved to London and he's got lots of cool science to tell us about. Maxi.
Thanks, Sandy. Um, so yeah, as Sandy mentioned, I just moved to London. The work I'll present here, I carried out in my previous postdoc with Jacob Scott at the Cleveland Clinic. Um, since I'm the first one to speak here, mm, maybe, here we go. Cool. Um, my research broadly focuses on, as many of here, the problem that cancers are complex ecosystems that dynamically change over time. And as we know, we've started to leverage that in form of personalized therapies, which have shown that if we adjust the treatment in terms of what we treat with to the individual patient, we can treat more effectively and more tolerably. Um, Building on top of that, a number of the people in this room, including myself, are interested in can we do the same now with dosing? So not only personalize what we treat with, but also how we use those drugs. Because at the moment, when we treat with a drug, we primarily follow the so-called maximum tolerated dose paradigm, which means that we try to give as much of therapy as possible to kill as many tumor cells as possible. And the only time we change that is when there's toxicity or when the treatment stops working. However, over the last couple of years, we've shown that there's benefit to personalizing dosing. Firstly, you can reduce toxicity because treating everyone at so-called maximum tolerated dose means we are going to overtreat some people. It also means we are going to undertreat others, and so there's also an opportunity here to increase efficacy by making sure we give enough treatment through personalization. And then finally, there's the opportunity to steer tumor evolution. And this is really at the heart of what I've been working on the last couple of years, and which was pioneered here at Moffitt, the idea of adaptive therapy. Many of you will be familiar with this, but since we do have new people in the audience, I thought I'd just briefly introduce it. Adaptive therapy builds on what I call the competitive release hypothesis, which says that when we have a patient like this, where we treat continuously and they initially respond and eventually start to have their tumor to grow back, the reason is that we have resistant cells pre-existing in this tumor, and that these cells are initially kept in check by competition with sensitive cells. But that when we treat, we basically remove those sensitive cells and we cause the competitive release of the resistant cells. Based on this idea, Bob Gatenby and others here at Moffitt pioneered the idea of adaptive therapy, which really is built on three pillars, I would say. Firstly, this idea that we try to control resistance rather than just eliminating it, and that we do so by using that competition with the sensitive cells. And we do that by giving enough treatment to keep sensitive cells around. Enough treatment to control tumor burden, but then stop or reduce dose in order to keep those sensitive cells around and use them with competition to delay resistance. The question that I want to address in this talk is that of how do we extend adaptive therapy or other approaches to personalized scheduling in an effective, safe, and feasible manner to other treatment settings. And the point I want to make really, and I thought I'd bring it up front since these are short talks, is that I think a really useful tool in this is the integration of experiments with modeling. And really, what I mean by that is true integration and iteration. And the reasons for that are that experiments provide us with an environment which we can fail quickly, safely, and cheaply. And modeling on the other side provides us with a tool set to understand what is going wrong and what is going right and learn from these failures. And so as satisfying as it is to get the model right, I actually believe in these settings, getting it wrong can be almost more informative. I want to demonstrate that using a case study in EGFR mutant non-small cell lung cancer. And then I don't have time today, but if you want to chat outside this, I also think there's lots of opportunity for the modeling community to sit down with the experimental community to help improve the experiments because they are not standard. And in that setting, I think there's a lot that we can do together to help come up with better protocols. Cool. Just briefly, non-small cell lung cancer is it has several subtypes that are driven by oncogenes, EGFR being one of those. And those are essentially kinases that get hyperactivated for a mutation and help promote tumor growth. So EGFR occurs in about 15% of patients, and there's been a series of drugs that have been developed over the years to target those mutations, which basically deprives the tumor of that growth factor and slows or eradicates tumor growth. However, unfortunately, the picture is kind of to what I showed earlier, that these drugs work really well for a couple of years at this point, but in over 90% of patients, the tumor eventually comes back despite continued treatment. And so what we're wondering in this project was, is this a setting where we can potentially do something with scheduling to help delay that time and have the drug be active for longer? To investigate that, we went to the wet lab, where Dagim Tadele, who was a postdoc in the lab at the time, had developed a system where we had sensitive cells that were sensitive to an EGFR inhibitor, and he derived a resistance cell line and tagged it fluorescently, which then allowed us to have both these populations and to monitor those through a time-lapse microscopy system, which kind of looks like this in the lab and allows us to, what we can do is we can basically take these cells, plate them together in a well, and then watch the population dynamics over time, which may look something like this. So on the top, you can see we get count data over time, and on the bottom, you can see we get the images and spatial data that's associated with this over time, which I believe is a fantastic system to start studying what's happening during scheduling. And so what we did is we used the system to start building a simple model to gain some intuition of what might be happening here. So we did experiments in which we first measured untreated growth and then treated growth. And as a first step, I just fitted a simple Lotka-Volterra model to this, because why make something more complex if we can start simple and take it from there? So I did that, and you can see the fits here. They're not perfect, but they're not terrible. So I thought, let's sort of start with this and see where it takes us. So I used this model and asked, would the model predict that intermittent scheduling would help us delay resistance in this setting? So here you can see the simulations. Left-hand side is a high-dose continuous therapy. The right-hand side is an intermittent on-off, where we treat for 3 days, then take the treatment off for 3 days, and do that for a total of 3 cycles. If you look at the resistance fraction at the end of that, you can see very clearly the model suggests that we can delay resistance here. That was exciting. So does this work in the lab? And the cool answer to that is yes. So here on the left-hand side, you can see a control well where we don't treat. In the middle, you can see a continuous high-dose treatment. And on the right-hand side, you can see the intermittent treatment. And the white arrows, I don't know if you can see this here, but they basically point at small resistant colonies that are present at the beginning. But then in the continuous case, you can see how it expands because there's lots of open space around it. And then the intermittent case, it ends up also expanding, but still being trapped in between these sensitive cells. So with these data, we are now interested, why does this work? Is it really about this trapping as we are hypothesizing? So to look into that, we used the fact that we had this spatial data. And so what we did is, in each well, we actually not only have one image that I just showed you, but we had 49 different ones. They're all slightly spatially distinct. And so what we used them for is to see in these different regions, what are the dynamics of the resistant cells? And specifically, we looked at 2 factors here. One being, at what point do we get a resistant colony that has a certain size, i.e., we have a patch here that previously was just sensitive and that got invaded from the outside. And the other factor we looked at was, once a patch is invaded and you have an established resistant colony, at what speed does that grow? With the question being, does intermittent therapy in this case prevent the establishment of new colonies and previously essentially uncolonized areas? Or does it slow down the expansion of existing colonies, or even colonies once they've started to form? And so looking at the time of when we get the establishment, you can see the distributions here across the 49 images in each of these experiments. And basically, there's sort of 2 parts to this distribution. There's the left-hand side, which are, in this case, all those patches or images where we had a pre-existing cell there right from the beginning. So this is basically a pre-existing patch. And that's about the same for all of them, which makes sense since that's really determined by the initial seeding. And then to the right of that, you can see in the invasion that is or isn't happening. What's interesting here is that really between the control and the on-off, there isn't a clear distinction. So we thought, okay, maybe one cell is a little bit noisy. What if we look at bigger? So if you set the threshold higher so that the cells really have to have themselves established before they count as a colony. And so if we do that, we get these pictures. And you can see that the shape of these distributions does change as we increase that threshold. And in particular, as we get to 50 cells, what you can see is that they are now for the control well, where we previously saw that we are really able at trapping the resistant cells. That distribution has shifted a lot to the right. But it hasn't really changed between the continuous and the on-off. So what that seems to suggest is that it's maybe not as much, the benefit of the intermittent scheduling here is not as much about preventing the invasion of a new site, but it is about down the growth of a colony, both sort of when it starts forming and even after it has started to form. And in line with that, when we actually measure those growth rates here, we can see that the growth rate of these resistant cells goes down in between the continuous and the on-off, validating that hypothesis. Cool. The next question we're then interested in is there a difference in how we schedule? So if we give the same dose in different ways, does it give us the same outcome, or does it matter how we give it? If you ask the model, it says, no, it doesn't really matter. And you can see the simulations here in the bar graph of the final resistance fraction there at the bottom. Interesting enough, if we now go and test this in the experiment, we see things don't quite line up. So here on you can see the dynamics that we see in the wells in the experiment. And you kind of, if you look to the right, which is the half dose continuous treatment, you can see that the total number of cells as well as the resistant cells is slightly higher than on the left. And if you look at this more statistically, that is confirmed. And interestingly enough, it's true both for the final resistance fraction as well as for the final cell count, suggesting how we schedule in this case does matter. It's not just about the cumulative dose. That, of course, then poses the question, why? What are we getting wrong in the model? And this is where I came back to some work that Jeffrey West here has been pioneering for a couple of years now around the idea of anti-fragility. It's essentially about the convexity of the dose response curve. Because if you look closely in this like very simple model that I was using, we assumed that the relationship between the dose and the drug kill is linear. And what that means is if we treat at a half dose, we're basically getting half the effect all the time. But it also means that if we're treating it at high dose for half the time and essentially no dose for half the time, we on average also get that effect. And so that is why in this model, it doesn't matter how we schedule. However, when we now go and estimate this relationship in our experimental system, what we see is that it's clearly not linear, but has a very strong concave curvature. And if you just sort of apply the same thinking here, what we can see is that now the half-dose schedule gives us quite a bit of cell kill of the sensitive cells, i.e. removing a lot of sensitive cells, whereas the on-off gives us less. And that is why we hypothesize that in this case, the intermittent schedule is more effective at delaying resistance than the low dose. And if we basically change this to a nonlinear response, then it also fixes it. I unfortunately don't have time to show this in the relations, but if you're interested, happy to do so afterwards. Cool. The final bit I wanted to talk about is what happens in terms of actual quantitative dynamics. You may have noticed that so far all I've done is sort of compare rankings of schedules. So how about actually making quantitative predictions? So in the first instance, I did that looking just at the control, like the untreated case, and the treated case. So I'm fitting to the first half of my data here and predicting on the second half. What you can see is that while there is a little bit of discrepancy, generally speaking, it's not bad. Kind of gets the key ideas and predictions right. So the next thing I then did is ask, given we get no treatment right and treatment right, if I just put them together, do I get that right? Interesting enough, and I think quite importantly, the answer is no. So here on the right-hand side is what happens when I take the model from the left-hand side and just predict what I think should happen in the on-off. And what you can see is that while the first cycle is okay, it very quickly goes away from there. The question of then that we looked into is, why is that the case? And looking at the cells, which we can do since we have the data for that, we can see that there's a stark difference in the sensitive cells as they go through the intermittent scheduling. So on the left-hand side here, you can see untreated cells, GFP cells, sensitive cells. And on the right-hand side, you can see these same GFP cells after 3 days on treatment and then 3 days off treatment. So these are currently without drug, but you can see visually here that they're not the same as those that had never seen drug before. And what that means is that there's probably two populations here of or potentially more of cells in this sort of sensitive GFP population. In the interest of time, I think I'll skip the next slide in which we looked at what is going on here in detail and just go to the end. And really, I think what I hope to bring across here is the benefit of integrating and really iterating, I would say, between modeling and experiments is a way of understanding what is happening during scheduling. I think in terms of the key takeaway from this work for me is, I think it's one thing to make predictions about what happens under continuous treatment. When we start looking at changing doses or making intermittent treatment, I think we need to be very careful because there's going to be non-linear effects that come in. So it's important, I think, to be mindful about making predictions in these cases and making sure to validate them as we design new schedules. With that, thanks for your attention.
Thanks, Max. If there's a short burning question, we can take it. Otherwise, go ahead.
Dimensional system to actually do your simulation, you can actually use a 3D-dimensional, which is actually more realistic in terms of tumor growth.
Do you mean experimentally in terms of like a 3D organoid?
Organoid type.
Mostly like ease experimentally, and to be honest, imaging as well. In 2D, it's like really easy to get the cell. Everything in 3D that's possible, but starts to get a lot harder quickly.
Okay, I think we need to move on.